Hello and welcome. Today we're diving deep into a significant kidney concern: aminoglycoside nephrotoxicity. This condition arises as a consequence of using aminoglycoside antibiotics, powerful medications vital for treating severe bacterial infections, but which, unfortunately, can have a damaging effect on our kidneys. Join us as we explore the causes, mechanisms, symptoms, and ways to manage and prevent this important medical issue. So what exactly causes aminoglycoside nephrotoxicity? The prime suspect is, of course, aminoglycoside antibiotics themselves. These drugs, which include gentamicin, tobramycin, amikacin, and others, are frequently prescribed to combat serious gram-negative bacterial infections. However, their chemical structure allows them to accumulate within the kidney cells, especially in the proximal tubules. Certain factors can increase the risk, including high doses of the medication, prolonged treatment duration, pre-existing kidney problems, dehydration, advanced age, and concurrent use of other nephrotoxic drugs like NSAIDs or diuretics. Let's delve into the pathophysiology, or how aminoglycosides damage the kidneys at a cellular level. Aminoglycosides are filtered by the glomerulus, the kidney's filtering unit, and then reabsorbed by the proximal tubular cells via endocytosis. Once inside these cells, they disrupt various cellular processes. They interfere with mitochondrial function, reducing ATP production, the cell's energy source. They also induce oxidative stress by generating reactive oxygen species, which damage cellular components. Furthermore, aminoglycosides disrupt the metabolism of phospholipids within cell membranes, leading to cell membrane instability and ultimately cell death, also known as necrosis. This widespread cellular damage reduces the kidney's ability to filter waste and maintain fluid balance, leading to nephrotoxicity. In terms of epidemiology, aminoglycoside nephrotoxicity is a relatively common complication in patients receiving these medications. Studies suggest that it can occur in anywhere from 10% to 25% of individuals treated with aminoglycosides. Although exact incidence rates vary depending on factors such as the specific aminoglycoside used, patient risk factors, and monitoring practices. Individuals who are elderly, have pre-existing kidney disease, or are receiving high doses or prolonged courses of aminoglycosides are at a higher risk of developing this condition. Now let's turn our attention to the signs and symptoms. Early on, aminoglycoside nephrotoxicity might not present with obvious symptoms. However, as kidney function declines, several telltale signs may emerge. These include a decrease in urine output, also known as oliguria, and fluid retention leading to swelling in the legs, ankles, or feet. Laboratory tests may reveal elevated levels of creatinine and blood urea nitrogen, or BUN in the blood, indicating impaired kidney function. Some patients may also experience electrolyte imbalances, such as low magnesium or potassium levels, which can cause muscle weakness, cramping, or irregular heart rhythms. In severe cases, the condition can progress to acute kidney injury, requiring dialysis. Diagnosis of aminoglycoside nephrotoxicity typically involves a combination of clinical evaluation and laboratory testing. The doctor will first evaluate the patient's medical history, focusing on aminoglycoside use and any risk factors for kidney disease. Blood tests are crucial to measure serum creatinine and BN levels, which are indicators of kidney function. A gradual increase in these levels during aminoglycoside therapy is a strong suggestion of nephrotoxicity. Urine tests can also provide valuable information, revealing the presence of protein or casts in the urine, which are signs of kidney damage. Additional tests, such as fractional excretion of sodium, can help differentiate aminoglycoside nephrotoxicity from other causes of acute kidney injury. In rare cases, a kidney biopsy might be necessary to confirm the diagnosis and assess the extent of kidney damage. Aminoglycoside nephrotoxicity doesn't have distinct classifications, but its severity can be graded. Mild cases might involve only a slight increase in serum creatinine, while severe cases can progress to acute kidney injury requiring dialysis. The severity helps determine the management approach. The cornerstone of treatment for aminoglycoside nephrotoxicity is to promptly discontinue the aminoglycoside antibiotic. Supportive care is crucial to manage the consequences of kidney dysfunction. This includes careful fluid management to prevent volume overload or dehydration. Electrolyte imbalances, such as hypokalemia or hypomagnesemia, need to be corrected. In severe cases of acute kidney injury, dialysis may be necessary to remove waste products and excess fluid from the blood, giving the kidneys time to recover. Close monitoring of kidney function and electrolyte levels is essential throughout the treatment process. Prevention is always better than cure, and there are several strategies to minimize the risk of aminoglycoside nephrotoxicity. First and foremost, use aminoglycosides judiciously and only when clearly indicated. When aminoglycosides are necessary, use the lowest effective dose and avoid prolonged courses of treatment. Monitoring serum drug levels can help ensure that the drug concentration stays within the therapeutic range and doesn't reach toxic levels. Maintaining adequate hydration is crucial to prevent drug accumulation in the kidneys. Avoiding concurrent use of other nephrotoxic medications, such as NSAIDs and diuretics, can also reduce the risk. Finally, regular monitoring of kidney function and electrolyte levels during aminoglycoside therapy is essential to detect early signs of nephrotoxicity. The prognosis for aminoglycoside nephrotoxicity varies depending on the severity of the condition and the patient's overall health. In many cases, kidney function recovers to baseline after discontinuation of the aminoglycoside and with appropriate supportive care. However, some patients may experience persistent kidney damage or chronic kidney disease. Recent research has focused on developing novel strategies to prevent and treat aminoglycoside nephrotoxicity. This includes exploring the use of antioxidants to reduce oxidative stress, agents that protect the proximal tubular cells, and alternative antibiotics with lower nephrotoxic potential. The hope is that these advances will lead to more effective ways to combat this potentially serious complication of aminoglycoside therapy.